Welcome to 2-Minute Anaesthesia in Critical Care. Today let's discuss albumin. Albumin is the most abundant plasma protein, accounting for 60% of sebum plasma proteins. It's a polypeptide chain consisting of 585 amino acids with a molecular weight of 66 kilodaltons. Albumin is produced by the liver. It is actively secreted into the portal circulation and is not stored. It's produced at a rate of 10 to 12 grams per day in health. It has a half-life of 2 to 3 weeks, and 40% is in the plasma compartment, while 60% is in the extravascular space, and this is recirculated via the lymphatic circulation back into the plasma circulation. It's broken down by most organs, including the muscle, skin and liver, within lysosomes to increase the pool of amino acids. A small amount is lost in the GI gut, however there's minimal loss in the renal system in health. It has a range of functions. These include maintaining oncotic pressure. It can bind to molecules including water, cations, fatty acids, hormones, drugs including barbiturates. It also has metabolic functions including drug inactivation, i.e. disulfiram. It's involved in plasma buffering, antioxidant and anticoagulant effects with heparin-like effects. Albumin, as mentioned, is the most abundant plasma protein, but there is additional proteins including globulins and additional ones. Globulins can be alpha, beta or gamma. Alpha could be alpha-1 antitrypsin, ceruloplasmin, beta, beta-2 metaglobulin, but also transferrin, and finally gamma globulins, which includes immunoglobulins. Others include fibrinogen and also regulatory proteins. Hyperalbuminemia is a single prognostic marker which leads to an increase in mortality, morbidity and hospital length of stay, irrespective of the underlying etiology. In critical illness, there's dysfunction of the endothelial barrier which leads to leakage of capillary albumin. The underlying etiology for this is unknown, but may relate to endotoxins, cytokines, complement and chemokines. In critical illness, there's a reduction in albumin mRNA production, leading to reduced albumin amount. There's also, as mentioned, increased transcapillary escape, and in sepsis this can affect up to 300%. There's also abnormal breakdown leading to a shorter half-life. It's important to remember that albumin is only one colloid and comes in varying concentrations, 5% or high concentrations up to 20%. But in addition to albumin, there's dextrins, which come in dextrin 40 or dextrin 60, based on molecular weight. There's gelatins, which are connective tissue from animals. An example is jelly fusion, and also starches. The best quality evidence within critical care relates to the use of albumin cirrhosis with the treatment of SBP, HRS, and large volume paracentesis. There's a range of other uses which have poor or harmful effects. Its use within sepsis and septic shock is debatable at reducing the volume of fluid administered, but this is inconclusive in regards to mortality benefits. Other uses include replacement for hyperalbuminemia, ARDS, cardiac surgery, diuretic response, acute brain injury, and also renal replacement therapy.